Welcome to our weight loss surgery seminar today. With so many options available that people are looking through for weight loss, it can be very confusing and overwhelming at times. And that's why our surgical team is here to help sift through all of that and discuss today in our webinar who is a weight loss surgery candidate and why those patients might benefit better from weight loss surgery compared to all the multiple other options that are out there. Before I get started, I would like to invite each and every one of you all to take our 60-second assessment that is available on our website to find out if you are a candidate for weight loss surgery. And stay tuned to the very end. I'll be answering any questions that may come up as we go through the presentation. So let's go ahead and get started. Okay, my name is Dr. Eric Lowe. I'm a general and bariatric surgeon in Capital Surgeons Group and Southwest Bariatric Surgeons here in Austin, Texas. I specialize in weight loss surgery, and I would like to share with you all today this discussion about who should consider themselves for weight loss surgery. I'm going to go through some of the things like prevalence of obesity and the effect of the weight on your health, myths about weight loss surgery that you may have heard out there. Maybe that's something that's keeping people from considering the operation. Going forward, some of the benefits and the risks of surgery, and then talk about the different procedures that we can perform here, the common procedures that I perform as a bariatric surgeon. And then at the very end, I'll have time to answer some questions for everyone and go over what are the next steps if a person should decide that they would like to at least have a consultation with a surgeon to discuss weight loss surgery. So I always start this talk with explaining to everyone what is the BMI, which is the body mass index. And that really helps us decide who, in fact, is a candidate for weight loss surgery. There are a range of numbers between about 19 to 25 where a person's BMI is normal. And so we start talking about overweight and obesity once the BMI goes higher than 25. But there's some classes of obesity that are considered more appropriate for weight loss surgery. So if a person has a BMI greater than 30, they're typically considered a class 1 obesity. Greater than 35 is class 2, and then greater than 40 is class 3 obesity, and that's also called morbid obesity. So anyone who has a BMI higher than 40 is considered morbidly obese. And then if the BMI is greater than 35 and the person has any weight-related health problems, that also is a category of morbid obesity. So we talk about these types of health problems that are related to the weight. I always tell my patients weight loss surgery is very helpful because yes, it will help you lose pounds on the scale, and that is the number one reason that people look for weight loss surgery. But you have to understand that obesity affects basically every single part of your entire body. And the weight loss surgery can help reduce those comorbidities or completely eliminate them altogether. So if you see on this slide here, just going around, it's things related to depression. There are lung issues related to sleep apnea and asthma, problems from the heart, high blood pressure, acid reflux problems. Some people have stress incontinence with their bladder because of their weight. Certainly the joints are affected, your back, your hips, your knees, shoulders. People have problems with their veins, with venous stasis and poor circulation. Diabetes and metabolic syndrome is a very common problem related to obesity. Some people can get non-alcoholic fatty liver disease, high cholesterol. So the list goes on. Literally think of any part of your body and your health system. If you're morbidly obese, there's a chance that the obesity can affect that. A lot of women get bariatric surgery. It's actually, I think, more common in women to get bariatric surgery even compared to men. And so I do like to highlight that there is obesity issues that are specifically affecting women's health. The most common things are some things that are simple, like menstrual cycle irregularities or a lack of a period, problems with infertility. I've had many patients that were struggling with getting pregnant, or they would get pregnant, have a miscarriage, and oftentimes it was related to their weight. They would be put on different medications that help lowered blood sugar, help them lose weight for pregnancy. A pregnant woman who is already, a pregnant woman who is obese has a 60% more likely chance of requiring a C-section for delivery rather than a vaginal delivery. So a woman who has a C-section if they ever get pregnant a second time, it's very uncommon to have a vaginal delivery after a cesarean. They call that VBAC, vaginal birth after cesarean, for future pregnancies. And then an obese woman who's getting a C-section, she's at a higher risk of having a hernia or wound infections. Some of the obesity not related to pregnancy is just that it has effects on the woman's hormones. So it changing the balance of the estrogen and the progesterone, testosterone, upset certain things that can lead to like hair growth on the chin or other issues related to changes in that ratio there. Even when it comes to things like cancer, we know that obesity is detrimental to a person's health related to cancer. Over half of endometrial cancers in the United States are attributable to a person being overweight or obese. If a woman's BMI is higher than 30, then she is 2.5 times more likely to develop endometrial cancer compared to a woman with a BMI under 25. And that goes up even to almost 4.7% times more likely a woman with a BMI greater than 35 can get endometrial cancer. Early life obesity, so a younger person, adolescent, or someone in their 20s, has associated higher risk of increased cancer through the rest of their life. And there is an evidence in some studies that there's a protective effect against cancer with weight loss surgery. It's not only endometrial, it's also breast cancer. So being overweight or obese has a higher risk of breast cancer, increased by 30%. If a woman has breast cancer and has been gone into remission, there is a shorter time to disease recurrence. So if she may get a recurrence of her cancer sooner if she's obese, or there's a greater mortality for both premenopausal and postmenopausal breast cancer. And so there are studies out there that look at bariatric surgery, and there have been studies that show weight loss reduction was associated with a reduced all cancer incidence in women who were obese. So how good is the surgery? How well can we get rid of these health problems that are related to the weight? So you can see this chart here. It's about a 95% chance of eliminating diabetes after weight loss surgery. It's about a 92% chance of eliminating high blood pressure, 97 of cholesterol. Even sleep apnea, which is the lowest one, is a 75% chance reduction or improvement in sleep apnea. So I have a lot of patients that they have to wear their CPAP mask. They have poor sleep at night. They undergo weight loss surgery. They lose, let's say 100 pounds, and suddenly now they're off their CPAP machine. They don't have sleep apnea anymore. So people are taking themselves off of, not taking themselves, but people are going to their doctor and able to come off diabetes medications, cholesterol medications, and such. So really amazing improvements in the health once a person has weight loss surgery. It's more than just the pounds coming off the scale. It improves a person's life expectancy. So we've seen studies where the mortality risk is higher once a person's BMI goes over 40. So a person with a BMI over 40 is 2.5 times more likely to have cause of death than a person with a normal weight, BMI under 25. So what does that really mean? It translates into how much longer would a person potentially live compared to a 25 BMI or a 24 BMI to a 40 BMI. So it's about a 7-year shorter life expectancy in a person whose BMI greater than 40 when you compare that to the life expectancy of a person whose BMI is 24, and go up to about a 55 BMI, the life expectancy increase doubles to 14 years. So I've had patients, and we've even had this conversation. It's a great thing. Like they came to see me before having weight loss surgery. BMI was 41. I see them at the 1-year anniversary of surgery. Their BMI is 25, and I'm like, congratulations, God willing, you may have just added 7 years to your life. It's a really powerful reminder of just what that BMI change can do for someone. If you're out there and you're considering weight loss surgery and you're wondering, am I alone? How many other people are going through this same problem? Just know that in the United States, the obesity epidemic is a big problem. It's over a third of adults live with obesity in the United States. It's affecting children now and adolescents. 1 out of 6 children are affected with obesity. It is a very expensive problem to treat the diseases related to obesity. So, hundreds and hundreds of billions of dollars are spent annually to treat the causes related to that. And it is an epidemic. Back in the 80s, it was only, you know, 10% or 15% of people were obese, and now here we are in the 2020s, and we are, up to almost, just over a third of patients now. Um, I want to address a little bit some of the myths that I have had patients share with me about bariatric surgery. Like they were very interested, but their family member, their spouse, their parents, whatever it was, said, they kind of try to talk them out of it because they heard a horror story that there's too many complications related to weight loss surgery and everyone regains their weight anyway. So why would you have surgery for something that's not going to work and things like that? So just wanted to go through what we have today with the advances in healthcare. Just imagine, technological changes since the year 2000 till today, 25 years later. We have laparoscopic surgery, we have robotic surgery that we do for bariatrics now. Anesthesia is, better. The plan of preparing a patient for surgery ahead of time is better. Now, just imagine like the changes that have happened in healthcare. So, on this slide, I want to highlight if you compare bariatric surgery's mortality rate, which is 0.2%. So people would say, oh, I don't want to have surgery because I'll die. You could die from surgery. It is a 0.2% mortality rate statistically nowadays for bariatric surgery. That's the same as gallbladder surgery, hip replacement surgery, and hysterectomy. So I just want everyone to realize that it's a very safe surgery. People do not die of bariatric surgery. Early on in the first beginnings of that surgery, there were higher mortality rates, but things have just improved so drastically that now the complication rate overall, total complication rate, and we include things like nausea and vomiting. We include things like wound problems, wound irritation, leaking from staple lines, bleeding from surgery. You put all those complications together, the total complication rate is less than 5%. And the average hospital stay for a person with bariatric surgery is 0 to 1 day. So I send patients home the same day, almost universally nowadays, where a person just comes in and does the operation, goes home the same day, just the way they would if they had their gallbladder removed. If not 1 day, then people stay overnight in the hospital for 1 night. So a lot of patients have already tried so many other ways to lose weight by the time they've made it to have a consultation with me to talk about bariatric surgery. And so, people have said, well, I've tried diet and exercise and, I failed at many attempts. And so I want everyone to know as well that it's a person is not alone in that situation. It's very common that diet and exercise alone is not effective enough once a person reaches a BMI of 40. We have our National Institute of Health in the United States that a panel of experts released a statement that it is nearly impossible to maintain weight loss for those affected by severe obesity by any means other than weight loss surgery. So it's about a 2 to 5% chance that a person with severe obesity is able to lose enough weight that will improve their health drastically enough that makes it worth it, and that they keep that weight off at 5%. So only a 2% chance. So let me say that the other way. If you are severely obese with a BMI of 40%, with a 40 BMI, there's about a 98% chance that it will be unsuccessful to lose enough weight and keep it off at 5 years. And that's just probably what many people have noticed in their own life. They've done diet and exercise. They kept it off for a little time, didn't make it to 5 years total, lost less than what they were hoping for. And there's outliers out there. I mean, I don't want to say it's impossible. There's definitely, 1 in 100 people, 2, 3 in 100 people can do it. But the rest of us, less common. And so a study with how long do people keep off the weight and how many patients keep that off with a gastric bypass, for example, is about 80% of people keep all the weight off at 5 years. So it's very much more successful with weight loss surgery, and the total weight loss is much more significant than what people achieve with diet and exercise alone. So who do we decide is a good candidate for weight loss surgery? First of all, it is understood that obesity is a very multifactorial problem. It is far, far more complex than simply just saying, oh, they eat too much, they're overindulging. There are genetic issues, metabolic issues, hormonal issues, psychological, central nervous system problems. Um, it is very multifactorial. And I don't want to say that surgery is the only answer. I do understand that diet and exercise do work. But again, it's just that 2 to 5% of people that can keep it off and have a significant enough. And so that all this evidence is basically how the NIH came up with their consensus that they basically said that surgery should be considered for individuals with a BMI greater than 40 or a BMI greater than 35 with significant health care problems. So that's typically where my patients sit. They're coming to see me with a BMI of 41 or 50 or whatever it is, and they have diabetes or high blood pressure, sleep apnea. I have certainly have many patients that don't have any of those health problems yet. They're young, maybe they're in their 20s or 30s, and they are borderline. They'll tell me, "Oh, I'm borderline diabetes," or My doctor said that if I don't lose some weight, eventually I might have to start high blood pressure medicine." So, the cost of obesity does take a toll, as you see on the screen here. The people that have these healthcare problems related to their weight, they're spending a lot in pharmaceutical costs. They have to purchase their medications for their diabetes or their blood pressure or a CPAP machine, whatever it is. Adults who are obese spend about 42% more on direct healthcare costs than with those patients related to them with a healthy weight. The total cost somewhere between 147 to 210 billion a year is the cost of treating preventable chronic diseases related to weight loss. And then as a BMI increases in a person, there's studies to show that so do their required number of sick days and medical claims from work. The obesity related causes of death add up to about 400,000 total deaths annually in the United States. Obesity is the second highest cause of what was considered preventable death, only after cigarette smoking. So, if you smoke cigarettes, quitting smoking is a huge risk factor reduction in preventable death. And number two, if you're obese, then losing weight is a huge reduction in preventable deaths. And so, again, that other slide I showed you where the mortality rate goes higher and higher as a person's BMI increase, just remember that once a BMI is greater than 40, it's about a 2.5 times increased risk of death from all causes. And again, the total amount of cost spent every year is just exceeding the hundreds of billions. So, what are the benefits of doing bariatric surgery that are essentially not related to the number of pounds lost? And I just go through quickly to tell people improvement of blood sugar and remission of diabetes, lowering a person's blood pressure, the reduction for the need for blood pressure medications, fewer medications overall. For females, increased fertility can be related to bariatric surgery, improved outcomes that are required for orthopedic surgery. So a doctor who performs orthopedic surgery, he might have a patient that comes into the office that needs a knee replacement, but their BMI is 41. They say, I'd love to operate on you, but you're right now your weight is too much to undergo knee surgery. The knee replacement has higher complications, and so I'd like you to lose weight so that you can go forward with your knee replacement surgery. Very simply, reduce your risk of death from causes. The lower your BMI goes back towards 24, 25, you're dropping that increased risk. And then in general, just overall improvement of quality of life. I've had so many patients tell me that they were, much less mobile. They spend a lot of time sitting. They only walk so far, and then they stop to rest. They have young kids. They want to play with them. They have grandkids. They want to play with them. They've been avoiding going to certain places, like avoiding going to the movie theater, going on an airplane, going to an amusement park, whatever it was. Just changes in their quality of life that was just directly tied to them being overweight. And then, like I said, I see them a year later, and they've lost all their weight, 100 pounds came off, and they've been able to reinvigorate their life with these other experiences they've been avoiding. But even just, living more healthy, sleeping better at night, being able to be more active, all those things that people say that really improves their quality of life. So the two main surgeries that are, I put these two together, a gastric bypass and a gastric sleeve. I put them on the same page because roughly their statistics are pretty close. Now, when a person comes to see me in the office for consultation, I really do say, I basically offer three surgeries, a gastric bypass, a gastric sleeve, and a duodenal switch. And I just want to talk with that patient individually and decide which of those three rises to the top. That's the best operation for a patient. But just as a high level overview, so you can see it here today on the webinar, roughly the extra body weight loss after a bypass or a sleeve is somewhere in range between 60 to 80% at about 2 years. I will say that sleeve kind of edges closer to the 60%, and then bypass edges up higher to the 80%. So just as a rough example, a person is 100 pounds heavier than what their ideal body weight should be for their height and gender. And so if you do a sleeve, you can expect to lose somewhere between 60 to 80 of those 100 pounds. And if you do a bypass, again, 60 to 80, but might be closer to the 80 for the bypass and closer to the 60 for the sleeve. The comorbidity resolution is very good. So you're having an 80% reduction in diabetes, high blood pressure, 70%, cholesterol, acid reflux, and sleep apnea. And these patients report very high improvement of scores on surveys where they say, what is your health-related quality of life? And so these scores are very poor before surgery, and then they check them 6 months and 1 year later, and these scores significantly improve, meaning that their quality of life is getting higher and higher. This is a picture of a gastric sleeve. You've probably seen something like this if you've been searching on the internet. In a nutshell, it is a gastric restrictive procedure where we use a stapling device to staple across the stomach. And I just kind of follow this inner curvature of the stomach. That makes a much slender, smaller stomach that gets full with a very small amount of food, but patients feel satisfied by that small amount. Once the food leaves through the stomach, it's going to go out into the intestine and travel through the intestine. So I tell people the laparoscopic sleeve is a restrictive procedure. It restricts how much food can fit into their stomach, but there's no changes in your absorption. When it leaves the stomach, it's going to go through all of your intestine. And this part of the stomach gets removed out of the body with a sleeve. And this is done laparoscopic with just several small little incisions on the tummy. A camera goes in through one incision. The working instruments go through the other ones. Benefits of a sleeve. It's number one, it's by the way, it's just one of the most common procedures performed by us here at Capital Surgeons Group in Southwest Bariatric. It's also nationwide, so that we're not alone in that. It's the most common procedure. It's restrictive, so you have a small stomach, you feel full faster. That's basically how it works. A lot of patients have improvement of all these conditions, like I said, and very good weight loss at the 2 or 3 year mark after surgery. Now, I do consider this as an outpatient procedure or an overnight stay. So most patients who are going to get a sleeve are going to come into the hospital or the surgery center, have their operation done, and get to go home the same day, sleep in their own bed that night after surgery. Next is a gastric bypass. So what's different about a bypass is rather than using the stapler to make a tube shape out of the stomach, we use the stapler to make a pouch shape out of the stomach. So that pouch is made right up here at the very top, and the pouch doesn't actually have the natural exit. So the natural exit is over here. The pouch needs an exit, so we'll take the intestine from downstream. I bring it up to the pouch and sew a connection there. So now food is going to come down in, come into the pouch. Again, it's very small, so you'll feel full with a small amount of food, but then the food will leave through the pouch and go directly into the intestine, and it bypasses going through the stomach, which is where the surgery gets its name. The juices from the stomach will flow their own way all the way down into a second connection. So the food's going one way, the juice is going the other way, and they mix here and travel the rest of the way through their intestines. So the bypass, it is restrictive, just like the sleeve is restrictive. A small stomach, you feel full faster, you feel satisfied by a small amount of food. But in addition, now the bypass has a malabsorptive component, meaning that not all the calories and nutrients that you're eating are going to be absorbed. And that's one of the reasons why the weight loss is a little bit stronger. How I was saying, between that 60 to 80% range, the sleeve kind of edges closer to the 60 and the bypass edging closer to the 80. That reduced absorption is what increases the weight loss for a patient. Very similar, major reduction in diabetes. Even longer studies that have gone out to 7 years later, still over 60% of patients with diabetic remission, meaning their diabetes went away at the time of surgery and it hasn't come back yet. Bypass now very commonly an outpatient procedure, meaning a person can go home the same day, but some people do stay overnight as well. Lastly is a procedure that I typically call it the duodenal switch. There's so many different names for it out there. So you can think of it as a sleeve with a duodenal ileostomy. Sometimes it gets the nickname SADI. All of those names basically mean one thing, which is if you take a gastric sleeve and a gastric bypass and you kind of combine the best of both of those procedures into one operation. It is a sleeve at the top of the stomach, so it's the same kind of a sleeve as a regular gastric sleeve. But the regular gastric sleeve, once you do the sleeve, the procedure is done. The food will be, like I said, leaving through the natural exit of the stomach through a regular sleeve. When you do a sleeve with a duodenal ileostomy or a duodenal switch, you do bring the intestine up to the end of the sleeve and sew a connection there so that the food will leave through the sleeve and jump faster into the intestine. It doesn't go through all of the intestine. So again, it kind of steals that idea from the bypass where it's not going through every bit of your intestine. And then what that ends up doing is having the same effect as a bypass where you have reduced absorption of the calories. But you also get the benefits of the sleeve, which is that small stomach and feeling fuller faster. Now, you do have changes in the gastric hormone production and gastric juice production, and that is actually what really jumpstarts the metabolism and improves your body's ability to lose weight very quickly. And there's up to 70 to 90% excess weight loss at 3 years with a duodenal switch. So I tell patients, how do you kind of pick, even just from a BMI standpoint? If the BMI is under 45, most of the time a sleeve is more than adequate to help the person lose enough weight to get to that healthy goal of about a BMI in the high 20s. If your BMI goes over 45, so if your BMI is under 45, maybe you're only 100 pounds overweight. When your BMI goes over 45, now you're maybe 120, 150, maybe 175 pounds overweight. You kind of get into where a bypass becomes the more ideal operation because the weight loss is a little bit better with the bypass. And then once your BMI goes over 50, now you may be at the 150 to 200 pounds overweight or 250 pounds overweight, whatever the case may be. The sleeve with the duodenal switch is now sort of becoming the more appropriate procedure. But again, that'll be a consultation with your surgeon when the time is right to decide like where do you fit in that spectrum of those three procedures. The duodenal ileostomy compared to the gastric bypass, though, has a few less risks of side effects like an ulcer or problems like what's called an internal hernia. So some patients, they need that extra malabsorption, but they don't want to take the risk of a gastric bypass getting an ulcer later, and they might choose to go with the duodenal switch in that situation. So next topic I talk to a lot of patients about is, what is my life like after bariatric surgery? And they've heard, their coworkers have had it and they tell them what their life is like, and they've read stories on the internet. And so everybody kind of has an after surgery story out there. And again, you can kind of get lost in all the information there. So typically what I see with my patients, I tell everyone that you're going to take about a week to 2 off of work because you're going to be in recovery at that time. And I do recommend that people avoid strenuous activity or heavy lifting. So especially if that is involved at work, it would be, you just need to be off enough time where you can get back to where you're lifting heavier objects again. The diet is a gradual and regimented diet progression. We have a dietitian on staff at Capital Surgeons Group and Southwest Bariatric that'll basically teach you what's the calendar after surgery. Week 1 after surgery, you're going to be on liquids. Week 2, you add in the next food. Week 3, add in so forth. And, you go from liquids to solids over that course of progression. Life after bariatric surgery is a lifelong commitment to healthy eating and focusing on protein intake and hydration. I mean, some people say, well, I waited on weight loss surgery for a long time because I didn't want to take the easy way out. And I was going to do it my way and do it my best with diet and exercise. And I always tell them, like, it's not like it's a cop out, like you're taking the easy way out. Like, you're still making dietary changes, lifelong lifestyle changes, healthy eating enough protein, make sure you're staying hydrated. It still requires that commitment there. There is long-term follow-up with a bariatric surgeon. So if I take out someone's gallbladder, I'm going to see them 2 weeks out after surgery. They're going to be healed. Their gallbladder is gone. They don't have any more pain. they may not ever see me again because they're healthy and well, and I'm happy for them, and they're all off back to regular life. When it comes to bariatric surgery, we do much more longer term follow-up. So I, for example, see my patients 2 weeks after surgery, 2 months after, 6 months after, 9 months after, 12 months after, because I'm just watching you through that process, that 1 year when all that weight loss is happening. And then once we get to about the 1 year mark, then I just do annual visits with patients just so I can keep up and make sure, over time, is there any changes in the weight over time, following up with labs to make sure your nutrition is still good and hopefully not having any deficiencies or just whatever the case may be. So a little bit longer follow up with a bariatric surgeon. And then, people take vitamins after surgery and supplements. So, for example, if you had a gastric bypass, most people are going to be on a multivitamin that has iron and B12 in it. They're going to take some calcium, and all those are on a daily basis. But I do tell people, you're trading not having to take your diabetes or high blood pressure, or high cholesterol, or acid reflux medications, and now all you have to take is a multivitamin with some calcium. So I think that's a good trade-off, if you ask me. Like I said, we do have a assessment for patients to take on our website, basically asking if you're a candidate for weight loss surgery. I would love to invite you all to take that assessment and see. It's very quick. It takes about a minute to do it. And you're typing in your age and your weight and your height and so forth, and kind of gives you an idea like, here's what your BMI is, and yes, you fit, or however that works. But with that being said, I'm happy to answer any questions at this time. I'm going to stop my sharing for a moment. Okay. So first question I have here, it says, does my insurance cover it? I called them and they said it's covered if it's medically necessary. So short answer is that the vast majority of our practice, we have patients that are using their insurance for that. Weight loss surgery is a covered benefit in many people's plans. I always tell everyone that insurances are all a little bit different. Like you might have United or Aetna or Blue Cross or whatever the case may be. The coverage is there, but they might have certain criteria that they want their patient to do. So this plan might say that you got to do, A, B, and C in order to get covered for bariatric surgery, like get a letter from your doctor or see a dietitian or whatever it is. And next one has a little bit different, and they're all a little bit individualized, but most all insurances, yes, do cover bariatric surgery. We have folks in our office that I call the advocates. The advocates basically like the insurance expert. So a person who makes an appointment with us, we will go through and verify their benefits and see, A, yes, is bariatric surgery a covered benefit in their plan? And then B, what are the actual things that insurance wants the patient to do in order to be basically approved for an authorization for surgery. Now, some people don't have bariatric surgery as a covered benefit in their plan. And so you just have to see, that's what our folks do. They just go into the policy that the person has and say, okay, here's the covered benefits, and oh, yep, here it is, bariatric surgery. That's one of them. Some people have what's called an exclusion, meaning that they don't have bariatric surgery as a covered benefit in their plan. For those folks, we do talk about the self-pay option for bariatric surgery. We typically do those surgeries in a surgery center where the costs can be lower, and so forth. But yes, there's patients that if they can't get their surgery covered by their insurance, then we have options for that for self-pay. Okay, I see another question here. What if I already had bariatric surgery? I have a gastric band. Okay, so I see a fair number of patients that we would consider like a revision. That means that they have had a bariatric surgery in the past. So for this patient in particular, when I see a patient with a gastric band, first of all, I don't put bands in. You will be hard pressed to find surgeons throughout the country that are still putting bands in. So number one, it's just more common that the top three surgeries are sleeve and bypass and duodenal switch. But there are people out there that have bands in. I do often have patients with bands that we're just removing the band. And we are converting them to a different surgery or revising them. It's called a revision or a conversion. So what we do in those situations is we go in laparoscopic just like we would with any other weight loss surgery. The band has a little buckle that goes around the stomach. We go in and cut away some of the scar tissue there, unbuckle it, it slips right off the stomach, take away a little bit more scar tissue up there, and then let's say this person is band to sleeve. So once the band is off and we're looking back at the normal stomach again, literally just do a sleeve like we would. I've done band to sleeve, band to bypass, band to duodenal switch. All those are options. Um, on the topic of revision surgery, some people have had a sleeve already, let's say. You can do a revision of a sleeve. You can turn a sleeve into a bypass, or you can turn a sleeve into a duodenal switch. So revision surgery is certainly a possible thing. That is a little bit more nuanced, and you need to talk to, like, when you come see me, like, that's a little bit more nuanced discussion is like, what's the right revision for a patient. So, but absolutely, yeah, we see a lot of patients with revisions. Okay. Do I have to lose a certain amount of weight before I can have surgery? So that I say that depends. So I always have the philosophy, like, a person is there to see me to get weight loss surgery because they're struggling with weight loss. So I don't feel like I should make you lose weight to prove that I can do surgery on you. Now, there are definitely situations if a person is extremely heavy, let's say, something in the high 400 or 500-pound range, which is uncommon. I mean, the most average patient I'm seeing is in the 200s or 300s. So, um, if there's something particular about that person's weight and I see that there's a value there that we could get a person to lose some weight before the surgery. But in general, again, most people are seeing me because they've already tried to lose weight. We do have a pre-op diet that we do before surgery to make sure that we can shrink the liver down. It's basically a low carbohydrate diet, and that just helps with the technical aspect of the surgery itself, just so the liver is not as heavy. But in general, once I meet you, we do start a healthy lifestyle program, but it's not like I don't have like a pounds criteria that you have to do. So in general, see me, we're going to consider weight loss surgery. We're moving forward with it. Start doing your best to begin that healthy lifestyle and those changes. But it's not necessarily like a pounds you have to do. Okay, this is actually very common question. I think these types of medications are so common. So this one's, I'm on Ozempic for weight loss surgery and I only lost 20 pounds. Can I still get weight loss surgery? And Ozempic is a injectable GLP drug that is very common right now. There's semaglutide and Wegovy and Manjaro and Ozempic and very similar that are all out there nowadays. So, this 20-pound weight loss, that's unfortunately what I'm seeing is a kind of a common total weight loss, 25, 30 pounds, something like that. So they are effective. I have many patients who've had that same result. I wanted to lose 30 pounds and sure enough, I did. Great. So there are people that can do that. But again, if you're 100 pounds over your ideal weight, those injections might only get you part of the way there. And then when I do meet patients that are taking that, typically it's more of just a safety when it comes to the anesthesia. So you usually want to be about 3 weeks off of those shots before you undergo any type of anesthesia. So if, let's say, you're already on Ozempic, but you've decided it's not going to work, I'm going to go with weight loss surgery. You basically at least need to know with the surgery date at this point, you need to stop that injection 3 weeks before. But the short answer is yes, you can still get weight loss surgery. How long do I have to be off work after surgery? I work from home on my computer. So all the surgeries are done laparoscopic with a robot. The benefit of those is very quick recovery. Small incisions don't hurt that bad. People are mobile immediately, like you're up walking around the night of the surgery. So most people can drive a car within 2-3 days. You can move about the house, so I do have patients that are like, yeah, I work from home. They're just going to be on a computer. I still say, give yourself a week. You're recovering from surgery. You don't need to just, rush back in, but yeah, you can be sitting at a desk on a computer pretty quickly after surgery. The more restrictive thing is again, the weight lifts, lifting heavy weights. So if you're working for, a delivery company or you're a nurse or something, you work with patients, you're going to move a patient from here to there. Like, obviously, yes, you should not be doing that in the first 2 weeks after surgery. 2 weeks is also when I see patients back in the office. So if I see you back in the office and I look at you and look at your incisions and we talk about how your recovery's been going, you feel good, you look good, you're healed up. Okay, great. Go back to your activities. There's not going to be any issue there. if I see that person at 2 weeks and maybe they're still recovering a little bit longer, that's a perfect time to make that assessment and say, okay, well, you got a pretty strenuous job. You're about 85% there. Let's give it one more week before we go back to work. So again, it's just a dialogue with patients, just seeing how they do and starting with that first follow-up. Um, okay, I only have one more question here. It's I have really bad diabetes, and my doctor says I have to be real careful if I have any surgery. So I'll just take that as kind of just health problems. Absolutely, I have patients that their obesity has led to many problems and they're, not as healthy as they were 20 years ago. Um, it would be treated like any other surgery. If this were hip surgery, if this were a hysterectomy, like I was showing before, gallbladder surgery, obviously we have our patients, if they have a primary care doctor, we communicate with the primary care, like, is your patient fit enough to have an operation? If they have a cardiologist, we'll get the blessing from the cardiologist. Um, Person with diabetes, do your talk with your primary care, your endocrinologist, whoever's doing that. Get the blood sugar in as usual of control as you can. But the surgery can go forward. It's very uncommon that we have to cancel a surgery or do whatever because of somebody's blood sugar changes. And again, the goal is the surgery. Like, your diabetes will go away because you got the operation. So we're the sooner we can do the operation, the better your blood sugar control will be. And honestly, we're trying to get you into um, remission of that problem. So um, that is it for the questions I see there. Great. So I hope you have benefited today from viewing this webinar. Um, Again, my name is Dr. Eric Lowe. I am a general and a bariatric surgeon at Capital Surgeons Group and Southwest Bariatric Surgeons in Austin, Texas, and the surrounding areas. Um, Next steps moving forward, if you decide that you are interested, again, I would invite you to take the 60-second assessment that's on our website at capitalsurgeonsgroup.com. Our website has a wealth of information. We have a learning center there that you can read about bariatric surgery. And also it has opportunities to click a button to request an appointment, and that'll get sent to our office. And again, once a patient requests that appointment, we'll get your insurance information. We will, before you come in, we'll go ahead and make sure we go through the verification of benefits and see what all coverages are there. And if so, then what are the requirements that are needed? And then I'd love to see you all in a consultation, and we can talk about what weight loss surgery might be best for you. Thank you very much. Y'all have a great day.